First speaker, Dr. Priya Murthy. Dr. Priya Murthy is the lab director at Spurs Hospital, Bangalore. Dr. Priya has completed her MD from Bangalore and is heading laboratory and blood bank operation for Spurs Hospital, Bangalore. Prior to this, she has worked for other corporate labs like Apollo Diagnostic, Lal Path Labs, Onquist Laboratories, Metropolis Healthcare. She has more than 21 years of experience in the diagnostic and service industry with experience in various fields of pathology, including hematology, clinical pathology, and quality. Her field of special interest are hematology, including bone marrow morphology and flow cytometry. She has also been a guest speaker on various platforms, those of AppCon and Hematocon, and has been a part of many bone marrow workshops. She has contributed chapters for various hematology textbooks and has few publications to her credit. Today, she will be teaching us about the diagnostic utility of bone marrow examination in non-hematological disorders. Over to Dr. Priya Murthy.
Thank you, Dr. Sabina. That was a warm introduction to Kaho as well as mine. Thank you so much. I'm sharing my screen. It's an exhaustive topic. I'll try to cover as much as I can, and I may be a little fast. Please excuse me for that because there's a lot to cover. So bone marrow examination we know includes bone marrow aspirate and bone marrow biopsy, and most common indications include red cell disorders, white cell disorders, megakaryocytic disorders, some malignancies, including myeloproliferative disorders, lymphoproliferative disorders, plasma cell disorders, etc. We also do bone marrow aspirates for diagnosis of storage disorders to determine the iron stores and any infiltrative disorders in all bone marrow failure states like cytopenias. We do bone marrow aspirates, including morphological examination, immunophenotyping, cytogenetics, and molecular studies. So, when the bone marrow aspirate is not sufficient, if it is a diluted marrow, either because it's procedural or because it's a hypocellular marrow, we resort to a bone marrow biopsy. If it is a focal disease, then also we prefer to do a bone marrow biopsy. And many metabolic diseases are also diagnosed with the help of bone marrow biopsy. So, marrow space infiltrating lesions lead to pancytopenia, which include direct replacement, which disrupt hematopoiesis, and there could be concomitant fibrosis. So, number of neoplastic conditions as well as non-neoplastic conditions lead to pancytopenia, including some osteopathies like osteopetrosis. So we know bone marrow is composed of both cells and stroma. Cells include the hemopoietic progenitor cells and the stromal cells. I think the doctor, my other colleague speaker will be elaborating more on that. Stromal cells include fibroblasts, fat cells, laminin, collagen, reticulum cells, endothelial cells, lymphocytes, mast cells, and macrophages. So there is a bone marrow microenvironment which consists of cells, structural fibrils, extracellular matrix. In my outline, as an outline of today's talk, I will be dealing with infections involving bone, storage disorders, metastasis, and osteopathies. So to begin with, in the first section, bone marrow infections. Let's begin with a case study of a 35-year-old male patient is admitted with low-grade fever of 2 months. Except one small cervical lymph node, there was nothing else contributory. FNAC showed a reactive lymphadenitis. Patient was given antibiotics uh, and showed no response. Fever persisted. There was loss of weight, no organomegaly. X-ray of the chest was non-contributory, and a bone marrow aspirate was advised. Aspirate was a dry tap, and bone marrow biopsy was then performed, and the imprint showed mostly acellular material with an occasional histiocyte. So this is what the bone marrow imprint study showed, occasional histiocyte, but what the bone marrow biopsy showed were sheets of histiocytes replacing the hemopoietic elements of the marrow. Now, to ascertain the nature of these histiocytes, we did a Zeal-Nielsen stain and a PAS stain, and they were full of acid-fast bacilli. And when we went back and saw the acellular material, which was also stained with Romanowski stain, they showed extracellular images of mycobacteria. A diagnosis of Mycobacterium avium intracellulare was made. So, granulomatous conditions of the bone marrow are not uncommon, and necrotizing granulomas are seen in a number of infections, like tuberculosis. Granulomas can also be seen in a number of other conditions like fungal infections, then sarcoidosis, Hodgkin's disease, and in cases of immunosuppression also. So they are not rare. Like I said, 0.3 to 3% of bone marrow biopsy show granulomas. Bone marrow aspirates usually don't show granulomas because of a reticulin deposit around the granulomas, which prevent aspiration of these granulomas. But these be picked up on bone marrow biopsies. We can see granulomas in tuberculosis as well as fungal infections. Then non-case-intic granulomas can be seen in sarcoidosis, autoimmune conditions, and malignancies. Ring or donut granulomas are seen in Q fever and Epstein-Barr virus infection. So this is a case of HIV where there is necrosis and number of histiocytes showing acid-fast bacilli. How does tuberculosis spread to the bone marrow? It is mostly a hematogenous dissemination called miliary tuberculosis. The tuberculous bacteria can infiltrate and settle down in the stem cells of the bone marrow, and the stem cells we know have a mechanism of natural drug resistance, infrequent division, and privileged immune status. And when infection persists, and it can get reactivated later. Granulomas can also be seen in sarcoidosis, non-caseating granulomas. And if we can be lucky, we can pick up these asteroid bodies and the calcified Schumann bodies within the granulomas. Fibrin ring granulomas or the donut granulomas, where there is a lipid vacuole surrounded by histiocytes and a dense eosinophilic ring, can be seen in Coxiella bonnetti infections, Epstein-Barr virus, and you can also see granulomas in Hodgkin's disease. So don't be alarmed and don't conclude it as just a granulomatous disease. If there is a Hodgkin's disease, they occur simultaneously. Other be seen in the bone marrow are malarial infections. This is of a gametocyte of a Plasmodium falciparum. Sometimes this malarial pigment can be seen in the macrophages of the bone marrow. We can pick up filariasis sometimes in the bone marrow aspirate as well. Now, Kala Azar or Leishmania donovan bodies also can be picked up. This is a disease quite rampant in the tropical and warm areas of the world, and it is spread by the sandfly, and the protozoan is spread by that. Patients present with fever, malaise, and sometimes a moderate to massive sterility. The peripheral smear shows anemia, leukopenia, and Rolex formation also with monocytosis. The bone marrow aspirate as well as the splenic aspirate will show these Leishmania donovan bodies. Now, these Leishmania donovan bodies are very small, oval, and they have a nucleus with a kinetoplast. A clue to this is the presence of associated plasma cells. They can be picked up on the bone marrow biopsy as well, where a number of these intracellular as well as extracellular LD bodies can be seen. Presence of plasma cells is a clue for diagnosis of this condition. So histoplasma is another infection where we can see capsule yeast cells within the macrophage. These can be associated with granulomatous lesions within the bone marrow. The histoplasma can sometimes be confused with LD bodies, but here the capsule, there is a definite capsule around each of these. And there we saw the nucleus and kinetoplast, but here these are small fungal elements with a capsule around it, which can end with PAR stain, and silver methenamine stain. Similar to this are cryptococcus. Cryptococcus also present show granulomas in the bone marrow biopsies, but these are much larger than the histoplasma, and the capsule of these cryptococcal organisms also can be picked up with silver methenamine stain. HIV infection can give rise to anemia due to a number of causes. It could be due to inadequate production, drugs, or autoimmune hemolytic anemia. And we know this, they are immunocompromised, so they have associated infections like Mycobacterium avium intracellular, histoplasma, cryptococcus, etc. They can have associated Hodgkin's and non-Hodgkin's lymphoma. And sometimes we see these giant proerythroblasts with cytoplasmic projections. These are the early erythroblasts with parvovirus infected by the parvovirus B19. So the other findings in HIV positive patients would be gelatinous marrow plasmacytosis, focal fibrosis, granulomatous lesions. So these are all the findings we come across in the bone marrow of HIV infected individuals. Going on to the next section, which is the storage disorders. Bone marrow biopsy is very useful in diagnosing storage disorders. We can directly visualize the storage cells and allows for identifying are laden with accumulated metabolic products, and these are due to defects in lysosomal hydrolytic enzymes or due to accumulation of various lipids and mucopolysaccharides in histiocytes. Some of them are Gaucher's disease, Niemann-Pick disease, C-blue histiocytosis, and hand cell histiocytosis. Histiocytosis, we know, are a group of disorders characterized by accumulation of histiocytes, macrophages, and dendritic cells or monocyte-derived cells in various tissues and organs. Now, according to the Histiocytic Society, the histiocytic disorders are divided into 5 groups: L group, C group, R group, M group, and H group. So I am going to be talking about the Langerhans cell histiocytosis, which belongs to the L group. This is a clonal proliferation of Langerhans cells resembling epidermal dendritic cells. The Langerhans cells or the dendritic cells are antigen processing cells located in the epidermis and lymph nodes, and they are originated from the monocytes. So we see these characteristic histiocytes in the bone marrow aspirate, and in the bone marrow biopsy, we see the Langerhans sites with a characteristic coffee bean nucleus type of a groove here, and they is mixed with eosinophils, lymphocytes, and macro. The newer classification of this is Langer is LCHSS, and then there are individual organ based. Number of organs can be involved, which includes bone, skin, pituitary gland, liver, spleen, and hematopoietic system, and lungs also in adults. These liver, spleen, the hematopoietic system, and lungs are considered the risk organs. So LCH with risk organ involvement, LCH with other organ involvement. So it is divided into these 5 types. The older classification was of 3: acute disseminated histiocytosis, unifocal LCH, and multifocal systemic LCH. So acute disseminated LCH is very severe systemic infection affecting children less than 2 years. They present with a skin rash on the trunk and scalp associated with hepatosplenomegaly and lymph nodes. If you do an X-ray, there would be lytic lesions in the various parts, various bones, and this hematologically we find come across cytopenias due to suppression of myeloid, erythroid, and megakaryocytic cells because the bone marrow is infiltrated with these Langerhans cells. The prognosis is very bad and it is rapidly fatal. What we come across are these Langerhans cells in the bone marrow aspirate with vesicular oval indented nucleus and abundant cytoplasm, and the same can be present in the biopsy also. Cytochemistry can be done, and they are alpha naphthyl acetate esterase and alpha naphthyl butyrate esterase positive. The bone marrow biopsy can be subjected to immunohistochemistry, and these show positivity for CD1A, Langerhans, that is CD207, S100, CD68, and HLA-DR. So this is a picture of CD1A positive, and if you do an electron microscopy, cytoplasmic Burbeck granules will be seen. These are the X-rays. You see these Burbeck granules in the Langerhans cells. So the other types of Langerhans cells, Langerhans cell histiocytosis are the Hans color Christian disease and CH, also as the eosinophilic granuloma. These are associated with histiocytes, eosinophils, and lymphocytes, and these histiocytes can be subjected to IHC for confirmation. The Hans color Christian triad involves a triad of osteolytic lesions in the skull and associated diabetes insipidus and exophthalmos due to retroorbital involvement. Next is the Gaucher's disease. Some of you may have come across Gaucher cells in the bone marrow. It is autosomal recessive transmission, and it is due to deficiency of glucose cerebrosidase. Accumulation of glucosyl cerebroside happens in the macrophages, and these can show infiltration into the liver, spleen, bone marrow, and brain. There are three different types: chronic adult, acute infantile, and subacute neuropathic. So these Gaucher cells are large macrophages with a small nucleus. They have tissue paper like crumbled tissue paper like appearance of the cytoplasm, and they are characteristically present in the bone marrow, liver, and spleen. They are trap positive, and associated biochemical investigations in these cases would be deranged LFT and serum angiotensin converting enzyme levels increased. So acid phosphatase level and ferritin is also high, and they show hypergammaglobulinemia. They also can be picked up with PAS stain. This bisected Gaucher spleen, and it shows sheets of histiocytes with bland nuclei and the tissue paper appearance of the macrophages. And this is PAS positive. Niemann-Pick's disease is autosomal recessive transmission, and it is due to deficiency of sphingomyelinase, leading to accumulation of sphingomyelin in histiocytes. Niemann-Pick cells can be seen in bone marrow, spleen, and liver, and these are vacuolated. It shows multiple small vacuoles within the cytoplasm of the macrophages with a small nucleus, and that is how you differentiate. If it's a foamy vacuolated cytoplasm, it's Niemann-Pick disease. If it is crinkled tissue paper appearance, then it is a Gaucher's disease. So there are three different types: type A, type B, and type C, and they can be stained with Sudan black B and oil red O. So these are pictures of the Niemann-Pick cells in the bone marrow aspirate and the bone marrow biopsy. This is a liver biopsy showing the Niemann-Pick cells. Coming to the next category of diseases, which includes metastasis. Now, bone marrow is one of the most common sites involved by metastatic tumor. Diagnosis of metastatic involvement of the bone marrow has a profound effect on the prognosis and treatment. Moreover, bone marrow can be involved by the neoplastic process without any abnormalities recognized in conventional imaging studies, bone scans, serum chemistry, etc. So let's begin with a case. This is of a 65-year-old lady admitted with fever of 3 weeks. She's an asthmatic on steroids, and she came. There was no significant findings in biochemistry or in culture. X-ray just showed diffuse osteoporosis, which was probably age-related, and was not reducing. She was still admitted, and we noticed had a limp 2 weeks later. The diagnosis thought was a multiple myeloma, and a bone marrow aspirate was advised. It was diluted, so then bone marrow biopsy was performed. Now, what did the bone marrow biopsy show? It was a hypocellular marrow, and these clusters of cells within the bone marrow biopsy. To ascertain the nature, we started a battery of tests, and these were CK positive, by which we had already lost the patient with extensive metastasis. So, bone marrow aspirate as well as bone marrow biopsy are very useful in picking metastatic disease of the bone marrow. So, infiltration can be suspected on the basis of bone pains, pathological fractures, any neuropathies, any unexplained hotspots in the bone scan, second degree myopathies or spinal cord compression. Then associated biochemical changes would be increased alkaline phosphatase, LDH, parathormone, calcium, and they may also present with anemia, pancytopenia, thrombocytopenia, or carcinocythemia. So bone marrow biopsies forms an important part of staging. And when it is diagnosed, it is upstages the malignancy to stage 4. So bone marrow biopsies in metastasis is also done when there are suspicious areas on the X-ray or scan, when there is PUO or anemia and weakness. Many times we have come across bone biopsies done for long-standing pyrexia, and we would have picked up the metastatic disease, and then the patient would have been subjected to radiological investigations, and the primary would have been the most common malignancies that can spread to the bone marrow include breast, prostate, and lung. And in children, it is the neuroblastoma and germ cell tumors that metastatize to the bone marrow. Bone scan usually is non-specific, but it is still used in detecting metastasis. It is expensive, but fractures, osteomyelitis, and Paget's disease also stimulate metastatic foci. It has to be corroborated with histopathological findings. In blood, we come across anemia, thrombocytopenia, leukoerythroblastic blood picture because of associated fibrosis. Very, very rare come across carcinocythemia or circulating tumor cells within the peripheral blood. Bone marrow aspirate or biopsy, that is the question. Now in if it is only a focal lesion, then biopsy will become more sensitive because the needle may not have hit the correct area. And if there is associated fibrosis or because of the metastasis and it becomes non-aspirable, then bone marrow biopsy is more useful. And in a bone marrow biopsy, the architectural patterns also help in recognition, and we can also see the marrow reserve. So with bone marrow biopsy, there are a number of other advantages. We can type the malignancy, we can do IHC on the biopsy to type the primary. So several studies are there, and it has been shown that a combination of bone marrow aspirate and bone marrow biopsy together will help in detecting the metastasis much earlier. Most commonly, it is the biopsy is done from the iliac crest. Why? Because this is across all age groups. The iliac crest has active marrow, so and it is quite visible as well. So when we come to the histopathology of bone marrow metastasis, tumor load is extremely variable. We could see isolated tumor cells where there are single cells or small clusters less than 0.2 mm, and which is usually detected by IHC or molecular techniques. Then there could be micrometastasis where tumor deposits are between 0.2 to 2 millimeters in diameter. Large masses can replace the hemopoietic elements of the marrow and cause total marrow replacement. Now, we can also ascertain the type of morphology and also have a look at the secondary effects that the metastasis has on the bone, on the hemopoietic elements, and how it interacts with the marrow stroma. So micrometastasis is defined as secondaries which are zero point 0.3 square millimeters containing up to 10 to the power of 8 cells. And presence of micrometastasis usually detects distant metastasis and early relapse, and it is very important in autologous bone marrow transplant. There could be focal deposits of the metastatic tumor. case of a rectal tumor with bilateral Krukenberg, where you can see sheets of signet ring cells and mucin secreting mucin pools replacing the hemopoietic elements of the marrow. This was musicarmin positive. Now, tumor myelopathy is best seen in areas where there is tumor and remnant of the marrow. Tumor myelopathy response of the stroma to the metastatic tumor deposits. We can come across lymphoid aggregates. There could be neutrophilic response, eosinophilic response, and there could be stromal edema as well. So whenever there is a metastatic deposit within the marrow, there is proliferation of blood cells from the margin of the invading growth, and you come across angiogenesis. So immuno can be performed just like you do any other for detecting any other unknown primary. If it is an undifferentiated tumor, you will do a battery of tests beginning with CK, Vimentin, LCA, and S100. And then if CK is positive, if based on the positivity, you will come to the conclusion of the origin of the tumor, and then you could add markers specific to the tumor to come across to diagnose the primary. Why do certain cancers metastasize so easily to the bone? It is based on the Stephen Page's theory of seed and soil. Now, bone is a dynamic organ. It has hematopoietic, stromal, endothelial, and many other cell types. It has osteoblasts and osteoblasts. And then tumor cells stimulate the receptor on these cells, and a pre-metastatic niche is formed within the marrow, which secretes cytokines and chemokines, which and attracts the primary tumor cells to reach the bone marrow and colonize here. Tumor cells then adapt to the microenvironment of the bone marrow, and they can enter into a dormant state or proliferate to form clinically identifiable masses. The type of metastasis depends upon the local interaction between the tumor cells and the bone remodeling system. So these, I'll show you some examples of, this is a case of a neuroblastoma. The aspirate showed clusters of small round cells, and the same was reflected in the bone marrow. The hemopoietic elements were replaced by sheets of these small round cells, which turned out to be 100 and NSE positive. 70% of children have marrow involvement in of neuroblastoma. Similarly, in CA breast, we have picked up tumors which then confirmed with the use of immunohistochemistry, ERCK, GATA3, and some undifferentiated carcinoma in a fibrotic marrow. This is one example. We've picked up CA lung with TTF1 positive, and some special stains can also be performed on the bone marrow aspirate, like musicarmin and PAS stains. This is a case of melanoma, which showed HMP45 positive on the bone marrow biopsy. So the other things that you come across in metastatic disease is associated fibrosis and necrosis. And we know that the bone marrow biopsy is not uniformly when it comes to metastasis. So if there will be only focal involvement, but if you come across fibrosis or necrosis, then it could mean that there are other areas of the marrow which could be having a metastatic deposit or something else, maybe infections also. Now, this is a case where there is extensive fibrosis, and you could see these clusters of metastatic cells. This was a case of CA breast that had metastatized to the bone marrow with extensive fibrosis. There may be she areas of only fibrosis, and sometimes application of immunohistochemistry can pick up some cells which are lurking in between or adjacent to this area of necrosis. Now, whenever there is metastasis, there are associated bony changes as well. There could be osteolysis. The osteolysis can be local, which can cause thinning of the bony trabeculae. Here, when there is, because just the physical presence of these tumor cells causes osteolysis, and here the calcium levels are usually normal. It can extensive osteolysis or generalized osteolysis in case of paraneoplastic syndromes because of the tumors secreting parathormone and the metabolism. There can necrosis or newborn formation where there is a newborn which is laid down on pre-existing trabeculae or adjacent to bony trabeculae. Osteoblastic lesions are usually specific to certain metastatic tumors like tumors from the kidney, breast, and stomach, usually result in osteoblastic lesions. Coming to the last section, that is the osteopathies. Now, osteopathies are usually underdiagnosed, and uh, bone marrow biopsies are usually not considered for the diagnosis of metabolic disorders of the bone. However, it is an attractive tool to assess metabolic orthopedic pathology. Because we can visualize the cortical and trabecular bone, generalized bone disease can be picked up. Metabolic osteopathies are the most commonest which can be picked up, and it's usually largely unexplored because it is done by orthopedicians, which they use large bore needles, and which causes a lot of pain to the patient. And processing also is an art, and the regular decalcification cannot be performed on suspected cases of metabolic bone disorders wherein it disturbs the pathology and it cannot be hence identified. So sometimes bone biopsy can be done for unexplained bone pain where there is increased serum alkaline phosphatase, alterations of serum calcium and phosphorus, delayed fracture healing, and other conditions like fluorosis and Albert-Schoenberg disease. Now, let us understand these lining the bony trabeculae. Uh, if you look at this picture, this is the biopsy of a normal bone where the bony trabeculae have uniform thickness, have a smooth line over here. There is no irregularities, and there is normal mineralization in these bony trabeculae. And lining these bony trabeculae are osteoclasts. Sometimes you can come across osteoclasts in bone marrow aspirates, which should not be mistaken for plasma cells. Plasma cells have this eccentric nucleus with a perinuclear halo, but these osteoblasts, the nucleus looks as if it is almost being pushed out of the cell. So this is the way you identify osteoblasts from plasma cells. Then there are osteoclasts. They are multinucleated giant cells. Occasionally can be seen in the aspirate also. Some of them can be seen in the bone marrow biopsy. They should not be mistaken for megakaryocytes. So in osteoclasts, they are separate nuclei, separate from each other. Whereas in megakaryocyte, they are lobulated nuclei, and that is how you differentiate the two. Of course, it becomes a little challenging when you when you have to differentiate these from the multinucleated megakaryocytes of MPNs, but this can be differentiated from the normal megakaryocytes. Some of the osteopathies which are detectable on bone marrow biopsies are osteoporosis and osteopenia, which are disorder, osteosclerosis and osteopetrosis also. And then these primary hyperparathyroidism and renal osteodystrophy, which are associated with increased serum parathormone and also have abnormal calcium and phosphorus metabolism. So this is a normal undecalcified section. You cannot do your regular decalcification that you do because this can alter the pathology that is seen. So they are embedded in plastic embedding media like methyl methacrylate, and then the bone is put in methyl methacrylate, and methyl methacrylate is a liquid, and once it is kept overnight, it hardens. So morning, these can be heavy duty microtomes. So they cannot be used on the regular microtome as well. And this is the von Cosa stain to identify the mineralization of the bone. It is to the presence of calcium in it. And this is the this is the bone, and this is the osteo uh, uh, mineralization, and hence uh, like there is abundant bone, but this is actually very thin. The mineralization fund due to lack of calcium is stained pink from the eosin. Does not stain by the von Kossa stain. Now, osteoporosis condition that can be on plain X-rays, but only after there is 30 to 40% loss of bone mass. So it is insensitive diagnosis technique of osteoporosis. The gold standard earlier trancortical ileal crest. Now there are graphic methods where bone density is measured to detect osteoporosis. It is, however, a common incidental disorder which can be picked up on bone marrow biopsies. Here you are seeing thinned out trabeculae, bony trabeculae, where there is sometimes loss of interconnections between the bony trabeculae. We see very and too much. And when we are doing this procedure, usually the needle just goes in very smoothly, and butter gives you the feel entering into butter. Ratio of mineralized bone to osteoid is not mineralized bone to osteoid is still maintained in osteoporosis. This is the buttonhole deformity where there is no interconnection between the bony much marrow and thinned out bony trabeculae. This can be picked up in many elderly patients where they have been biopsied for some other reason. Osteomalacia and rickets, there is failure of normal or timely mineralization because of deficiency of vitamin D. Vitamin D can be deficient either because of deficient intake or endogenous synthesis or abnormality in the metabolism. Although the total osteoid is increased, the bone is very soft. So in rickets, there is abnormalities of iliac crest, there is overgrown cartilage and irregular deposition of osteoid. So there is, in this condition, there is too much bone and too little marrow. Marrows can sometimes show fibrosis. These patients will present with pancytopenia. So you're seeing here, when stained with von Kossa, there is irregular deposit of staining of the mineralized bone and very thickened osteoid which is devoid of calcium. Osteosclerosis is another condition where there is increased mineralized bone mass. It is seen in number of conditions like myeloproliferative disorders, metastatic carcinoma, systemic mastocytosis, Paget's disease, and multiple myeloma. Can be picked up on X-ray, and histologically, there is new bone deposited on the endosteal surface with irregular spicules of metaplastic woven bone. So you would have seen this in a number of primary myelofibrosis cases, advanced cases, where there is deposition of the distinct tabaculae as well as formation within the marrow spaces, and connected, which again gives rise to too much bone and too little marrow. Hyperparathyroidism is another condition giving rise to very classical changes in the marrow, either due to parathyroid adenoma or hyperplasia of the parathyroid. Initially, there is increase of osteoblasts. This stimulates production of osteoclasts. So, what do these osteoblasts do? When they are present in normal number, they are responsible for maintaining the normal structure of the bony structure. But when osteoclasts are increased, they start nibbling at the bony surface and cause irregular scalloped edges of the bony trabeculae. And I'll show you these pictures. This is a picture of a parathyroid hyperplasia with showing lytic lesions in the bone, and an advanced condition where these can the osteoclasts start nibbling the bony trabeculae. They go right inside and dissect out the trabeculae, form fractures. This is not seen very often. Similar pathology is seen in renal osteodystrophy as well. Because of abnormal vitamin D metabolism, parathormone is increased secondary to chronic hypocalcemia. So it can increase because of aluminium toxicity because these patients undergo regular dialysis. And there are three different types of renal osteodystrophies that we come across. So in chronic renal failure, in addition, these osteoclasts start nibbling at the trabeculae, cause scalloped edges. There is paratrabecular fibrosis. So next time you come across any renal biopsy, bone marrow biopsy on a renal patient, look out for paratrabecular fibrosis as well as these irregular bony trabecular surface. So normally it looks like this. Now there is, because the osteoclasts start nibbling at the bony surface, there is surface resorption and they start going into the trabeculae. This is known as lacunar resorption or Hauschip's lacunae. And this is tunnel resorption. The marrow here is replaced by fibrosis. And once the osteoclasts start nibbling at these bony trabeculae, they go through the bony trabeculae and cause these lacunae as well as dissect it out and form the cysts, which we saw in the fibrosis cystica. So another case is a case of a 1-year-old child presenting with pallor and stunted growth. He had a spleen and a liver which was enlarged, showed anemia count, and total count was normal, platelet showed a leukoerythrocytic blood picture with normoblast, left shift, teardropped RBCs. Because of this, it was advised to rule out a hemolytic anemia. Retic count was 1.5%, so hemolytic anemia was ruled out. There was no hemoglobinopathy or G6PD deficiency, and a skeletal survey was advised. And this is what it showed. The deformity of both femur with increased density of band-like densities within the femur as well as the ribs. This is a condition known as osteopetrosis. Osteopetrosis is due to excessive production of osteoclasts. Uh, sorry, failure of action of osteoclasts. These osteoclasts fail to resorb the bone, leading to thickened sclerotic bone. And because there is failure of resorption, there is irregular deposition of the cartilage as well as the bone, leading to subsequent fibrosis of the marrow. Patients pallor and hepatosplenomegaly. It is a genetically heterogeneous disorder of unknown etiology, has an autosomal recessive transmission, and mutations in the ATP6 gene has been identified in these cases. We can come across crystal deposits also. This is a case year-old male. He underwent transplant for end-stage renal disease, and 2 years later, he had a graft rejection and thrombocytopenia. And the bone marrow biopsy showed deposits of these crystals in a radial manner with an associated foreign body giant cell reaction. So take-home message is, for all aspirates and biopsy, examine in it under view. You may come across some granulomas or some other metastatic deposits which can yield valuable information. All cases of PO should be subjected to bone marrow biopsy to rule out granulomatous disease as metastasis. Stains like reticulin stain, Mason's trichrome, ZN, PAS stain should be done where the diagnosis is not apparent. Numerous infections with systemic manifestations can be recognized by examining the peripheral smear as well as the bone marrow. It is very useful in staging malignancies and also for detecting the unknown body. Whenever there is bone marrow necrosis, fibrosis, if that is all that you find, then please look further or probably repeat biopsies on the other side to identify something more sinister. Bone marrow trephine biopsy is a useful tool for detection of unexpected and expected osteopathies. The correct histology with high index of suspicion and clinical, radiological, and biochemical data gives rise to the accurate diagnosis. With that, and just as a prelude to Teachers' Day tomorrow, I'd like to thank my mentor, Professor Dr. Tejinder Singh, who has been responsible and has guided me a lot in understanding bone marrows. And some of the cases of osteopathies, particularly, were contributed by Sir. Thank you so much, Sir. And with that, I end my talk.
Thank you, Dr. Priya, for an excellent talk and very lucid cases covering right from the parasitic infection to granulomas to osteopathies and metastatic. I think that was a treat. And yes, it did remind us of Dr. Tejinder Singh's lectures, beautiful slides and lovely presentation of the patient stains and all. And I think this is a must watch for all the postgraduates. Um, and I think we'll all recommend to our postgraduates the recording of this lecture. Thank you, Dr. Priya.